There are two types of parenteral nutrition, central and peripheral. Peripheral venous nutrition is delivered through a peripheral vein and therefore has a decreased total osmolarity. The maximum osmolarity tolerated by a peripheral vein is only 900 milliosmoles per liter. Additionally, peripheral venous access must be changed frequently to maintain patency of IV lines. This usually means every 2 to 3 days. Increased volume is also required to decrease overall osmolarity when delivering this nutrition. Unfortunately, 100% of energy needs cannot be met through this form of nutrition, and patients typically require large volumes, so it is not appropriate for patients requiring any sort of volume restriction. Alternatively, central venous nutrition is administered through a central vein and is therefore the preferred method of delivery. These solutions are hypertonic and are not recommended for infusion through peripheral access because they exceed 900 milliosmoles per liter. Determining energy needs for parenteral nutrition can often be difficult. Energy needs are best determined using indirect calorimetry or metabolic carts. However, these are not available in all institutions due to the cost of these instruments. Additionally, they're not always feasible in critically ill patients, as some patients may have too high of oxygen requirements or may require supplemental oxygen, which could alter the readings. Most frequently, clinicians use some sort of predictive equation to determine energy needs. Energy requirements should be noted to be increased in patients that are critically ill, are septic, or are post-op. According to Aspen, hypocaloric feeding is recommended for obese patients or those with a BMI greater than 30. Aspen states that the goal parenteral nutrition should not exceed 60 to 70% of target energy expenditure, or roughly 11 to 14 calories per kilogram of their actual weight, or 22 to 25 calories per kilogram of their ideal body weight. More simplified calculations are often used by clinicians in day-to-day calculations. This is a simple table that can be used to determine energy needs based on a patient's BMI. As you can see, as a patient's BMI increases, their calorie needs decrease. Note that all energy needs are calculated based on actual weight. No adjusted or ideal body weights are used for these calculations. Protein requirements vary from patient to patient and are based on age, body composition, activity level, renal function, and wound status. In general, protein needs are increased in patients that are septic, post-surgical, or those that have wounds. Additionally, protein requirements in overweight and obese patients are increased and based on ideal body weight. The theory is that one should try to feed lean body tissue in an effort to preserve it during critical illness. These patients should be given at least 2 grams of protein per kilogram for obesity class 1 and 2, and at least 2.5 grams per kilogram for obesity class 3. Next, the components of parenteral nutrition will be discussed. Dextrose, or carbohydrate, provides 3.4 calories per gram. A variety of different dextrose solutions exist in institutions and can range from 5 to 70% dextrose. Glucose oxidation rates, or the rate of infusion of dextrose, should be kept below 5 to prevent hyperglycemia. In critically ill patients, the glucose oxidation rate. Amino acids, or protein, provide 4 calories per gram. These also come in a variety of concentrations, ranging from 3.5 to 15%. Lipid, or fat, is the final component of parenteral nutrition. The calories per milliliter depend on the lipid concentration. 10% lipid provides 1.1 calories per milliliter, 20% 2 calories, and 30% 3 calories. Lipids should be provided to prevent essential fatty acid deficiency, as this can occur in patients receiving no lipid in parenteral nutrition for at least 20 days. Only 4% of total calories from lipid are required to prevent this deficiency. Additionally, calories from lipids should not exceed 30% of total calories or 1 gram of lipid per kilogram of body weight. Total volume of parenteral nutrition is calculated based on concentrations of dextrose, amino acids, and lipids. The total volume will depend on your institution's compounding of parenteral nutrition, whether it be a 2-in-1 solution or a 3-in-1 solution, along with the concentrations of each of the ingredients. Some institutions recommend meeting a patient's volume needs with parenteral nutrition, while others maximally concentrate their nutrition while the patient is hospitalized. Here is a sample calculation of determining parenteral nutrition needs. A 46-year-old female had a small bowel resection due to ischemia. She presents at 67 inches, 155 pounds, with a BMI of 24.3. The parenteral nutrition ingredients available at this institution are 10% amino acids, 70% dextrose, and 250 milliliters of 20% lipid. These are provided in a 2-in-1 solution of amino acids and dextrose, with lipids hanging separately. Calorie needs are estimated at 25 calories per kilogram, which provides 1761 total calories, and 1.5 grams of protein per kilogram, which provides a total of 106 grams of protein. Ooh. The first step is to next, glucose oxidation rate is determined. 246 grams of dextrose times 1,000 milligrams provides us with 246,000 milligrams of dextrose. This, divided by the number of minutes in a day, or 1440, leaves us with 171 milligrams per minute. Dividing this by the patient's body weight of 70 kilograms leaves a glucose oxidation rate of 2.44 milligrams of dextrose per kilogram per minute. Because this value is less than 5, this infusion rate is safe and appropriate for this patient. Finally, total volume is calculated. 1,060 milliliters from amino acids, plus 351 milliliters of dextrose, plus 1 to 200 extra milliliters left for electrolytes, vitamins, and minerals, leaves us with a total volume of 1,600 milliliters. This institution maximally concentrates its parenteral nutrition, so no additional fluid will be provided. Next, we'll talk about electrolytes. First is sodium. Normal serum ranges range from institution to institution, but in general are between 135 to 145 millimoles per liter. A patient's baseline sodium needs are 1 to 2 milliequivalents per kilogram. For instance, if a patient was 75 kilograms, they would then need 75 milliequivalents of sodium. Sodium is added to parenteral nutrition as a salt of chloride, acetate, or phosphate. Sodium binds with both chloride and acetate in a 1-to-1 ratio, and in phosphate in a 4-to-3 ratio. Symptoms of hypernatremia or high sodium are lethargy, confusion, irritability, seizures, and myoclonic jerks. Symptoms of hyponatremia include nausea, vomiting, headache, confusion, fatigue, seizures, and coma. Management of normal serum sodium is essential when providing parenteral nutrition, but note that oftentimes sodium can be altered by a variety of other factors aside from nutrition. Normal serum potassium values are 3.4 to 5.3. Most people aim for a goal of 4.0. Again, a person's baseline potassium needs are 1 to 2 milliequivalents per kilogram. To raise a patient's serum potassium by 0.1, an additional 10 milliequivalents of potassium are needed. For example, if a patient has a serum potassium of 3.6, an additional 40 milliequivalents are required to reach the goal serum value of 4.0. However, elevated potassium levels do not follow the same rule. If a patient had a level of 4.4, subtracting 40 of potassium wouldn't necessarily get them down to 4. Potassium can also be added as a salt of chloride, acetate, or phosphate. It binds 1-to-1 with both chloride and acetate, and in a ratio of 4.4 to 3 of phosphate. Symptoms of hyperkalemia include nausea, irregular pulse, arrhythmias, and weakness. Symptoms of hypokalemia include severe muscle weakness, paralysis, respiratory muscle weakness, ileus, arrhythmias, cramps, tetany, muscle tenderness, and atrophy. As you can see, alterations in serum potassium can have drastic effects on a patient's overall well-being, so potassium levels must be monitored frequently. The normal serum range of calcium is 8.7 to 10.7 milligrams per deciliter. Most patients require somewhere between 10 and 15 milliequivalents per day. Note that many patients have low serum calcium levels during hospitalizations due to low albumin. Therefore, calculating a corrected calcium or checking an ionized calcium might be necessary to obtain accurate measures of calcium status. Caution is required when administering calcium along with large amounts of phosphorus due to the fact that calcium and phosphorus may form a precipitate which could cause a clot. Calcium is added as calcium gluconate. Serum levels of phosphorus range from 2.5 to 4.6. A patient's baseline needs is somewhere between 20 and 40 millimoles per day. An easy way to calculate a patient's baseline need is 0.15 to 0.25 millimoles of phosphorus per gram of dextrose to be given. Goal serum phosphorus is 4.0. Symptoms of hyperphosphatemia include hypotension and symptoms of hypocalcemia. Symptoms of hypophosphatemia include decreased red cell 2,3-DPG levels, decreased levels of intracellular ATP, metabolic encephalopathy, impaired heart or myocardial contractility, or muscle dysfunction. Hypophosphatemia often occurs as part of refeeding syndrome, so high levels of phosphorus may be required to prevent negative side effects of low serum phosphorus levels. Normal serum values of magnesium are 1.6 to 2.7 milligrams per deciliter. Most patients need somewhere between 8 and 20 milliequivalents per day. 1 gram of magnesium is equivalent to 8 milliequivalents of magnesium. Most IV writers of magnesium are given as grams versus milliequivalents, so a conversion factor can be helpful. An addition of 8 milliequivalents raises serum magnesium by 0.1, in a similar method to potassium. Therefore, if a patient's serum magnesium is 1.8, in order to get to the goal of 2.0, an additional 20 milliequivalents of magnesium are needed. Magnesium is added in the form of magnesium sulfate. Symptoms of high magnesium include nausea, flushing, headache, somnolence, ECG changes, and muscle and respiratory paralysis. Symptoms of low magnesium include neuromuscular side effects such as tetany, hypokalemia, and changes in an electrocardiogram. A ratio of chloride and acetate ions can be changed to affect serum chloride and bicarbonate. Giving a higher ratio of chloride will increase serum chloride levels. A normal serum range is 98 to 108 millimole per liter. A higher ratio of acetate will increase serum CO2 levels. Normal serum ranges are 20. Chloride and acetate are added through electrolytes and amino acids. Electrolytes can be formed as either salts of chloride or acetate. Additionally, amino acids have a standard concentration that contributes to the total ion pool. Travasol, one formulation of amino acids, provides 40 milliequivalents of chloride and 88 milliequivalents of acetate for every 100 grams provided. Sodium and potassium bind in a 1-to-1 ratio with both chloride and acetate. Phosphorus preferentially binds with sodium in a 1.331-to-1 ratio. It also binds with potassium in a 1.47-to-1 ratio. Multivitamins should be added daily to parenteral nutrition to prevent vitamin deficiencies. Listed below are recommended daily intakes of IV vitamins. Similarly, trace elements should be added to parenteral nutrition formulations daily to prevent trace element deficiencies. Of note, patients with increased ostomy or stool output have increased zinc requirements. Other medications can be added to parenteral nutrition. Famotidine or Pepcid can be added at a dose of 40 milligrams per day. Patients with impaired creatinine clearance or less than 50 milliliters per minute should receive only 20 milligrams per day. Regular human insulin can also be added to parenteral nutrition to assist in glycemic control. Insulin should not be added unless glucose levels are consistently over 180 milligrams per deciliter to prevent hypoglycemia. Dosing for insulin has been controversial and is often managed by endocrine service in the hospital. Typically, standard insulin doses start at 0.1 units of insulin per gram of dextrose. If this amount of insulin is not sufficient to maintain glycemic control, insulin is then incrementally added by units of 0.5. Here is another example. A 64-inch, 145-pound female has the following labs. She requires central venous nutrition due to a small bowel obstruction. She has been NPO and unable to tolerate liquids for 8 days. First, one should determine macronutrients. Because her BMI is 24.9, 25 calories per kilogram is appropriate. This will provide a total of 1,650 calories per day. Next, she should get 1.5 grams per kilogram of protein. This will provide 99 grams of protein a day. 250 milliliters of 20% lipid solution will provide 500 calories per day. This is approximately 30% of total calories and is therefore safe to administer. Again, to determine dextrose, calories from protein and calories from lipid are subtracted from the total number of calories required, leaving us with 754 calories. This divided by 3.4 calories per gram gives 222 grams of dextrose. Finally, electrolytes will be determined. This patient's serum sodium of 142 falls within the normal range. Therefore, sodium should be dosed at 1 milliequivalent per kilogram, providing 66 milliequivalents. A potassium of 3.8 falls below the goal range of 4. Baseline needs of potassium are 1 milliequivalent per kilogram, with an additional 10 milliequivalents needed to raise the serum value by 0.1. Therefore, a baseline need of 60, with an additional need for 20 milliequivalents to raise potassium to 4, provides us with 80 milliequivalents of potassium. A phosphorus level of 3.1 falls within the normal range. Phosphorus should be dosed at 0.15 to 0.25 millimoles per gram of gold dextrose. Choosing a value in the middle of 0.2 multiplied by 222 grams of gold dextrose will provide 44 millimoles of phosphorus. Magnesium of 1.9 is below the goal of 2.0. A patient's baseline magnesium needs are 8 to 20 milliequivalents per day, with an additional 8 milliequivalents needed to raise serum values by 0.1. Therefore, providing a baseline of 20 milliequivalents with an additional 8 milliequivalents will provide us with 28 milliequivalents of magnesium a day. Chloride and acetate ratios are changed to affect serum chloride and CO2 levels. A serum chloride of 101 is on the low side of normal, while a serum CO2 of 28 is on the high side of normal. Therefore, provision of more chloride to acetate should help normalize these values. Providing a ratio of 2/3 chloride to 1/3 acetate will provide 71 milliequivalents of chloride and 143 milliequivalents of acetate. This concludes the presentation on parenteral nutrition writing. Please feel free to contact any member of our team with any questions.